So greetings, everybody. Some people are still rolling in, so we'll just give it another minute or two before we get started. Thank you. Everybody, my name is Diana Chang Blanc. I'm from WHO Immunization Vaccines Biologicals Department. Thank you all so much for joining. We were holding for a bit because one of our presenters is not yet joined, but hopefully as the session goes forward, she'll be able to jump on. So thank you so much for joining. This is our session on vaccination strategies in humanitarian settings or for populations of concern, including refugees, IDPs, and migrants. Can we have the next slide? Yes, I just think I said that. Sorry, I said it before the screen came on. So that's the title of the session. Next slide, please. And for those who are new to this Learning Collective initiative, this has been established under the COVID-19 Vaccination Partnership, where the goal is to collect and consolidate and share lessons learned on country practices, particularly targeted at the 34 countries of concern that were under 10% of COVID-19 coverage in January. And it's primarily directed at those who support countries or those who are coordinating or implementing COVID-19 vaccination in their countries. Next. So is the slide on the sessions is next or no? Okay, sorry. So this is the 5th session in a series, and we will have another session coming up next month. For this slide, this was to make an announcement of something we just launched called the Global Compendium of Country Knowledge on COVID-19 vaccination. So as you can imagine, we've had very rich experiences in the turmoil of COVID-19 over the year 2020 and 2021. So we have now launched what we call the Global Compendium, which is a collection of different documented country experiences, country case studies, post-introduction evaluations, and synthesis reports on those evaluations that can be found on the link. And thank you very much, Alex. I see you've put it into the chat. I would ask you to bookmark it because it's actually a really useful reference. We have about 100 different experiences now documented on that Global Compendium. So not only are we asking you to access it and reference it, but also share your own experiences. If you are interested in collaborating with us on documenting more experiences, please feel free to contact us. You have one of my colleagues at the bottom of the slide there, Alejandro Ramirez Gonzalez, who is coordinating that information. So please feel free to reach out. We'd be, in fact, very enthusiastic about collaborating with you if you'd like to share your experiences. Next. Aha, okay, so my slides were out of order in my head. So as I said, this is the 5th in a series of sessions that we have. We have one more coming up in mid-November. And today we're very honored to have 3 different speakers, in fact, not just 2. And we were going to kick off with Anne Burton from UNHCR. Then we have the Ministry of Public Health from Lebanon, And thirdly, in fact, we've had a replacement speaker from UNICEF Sudan, Dr. Islam Hamed, who hopefully will be able to jump on shortly, if not already. So with that, can I go to the next slide? I think I just spoke to this of how to go. Then Santosh.
Yeah, thank you, Diana. I'm just going to walk you through a few housekeeping slides before we get started. Can we go to the next one, please? So for this Learning Collective session, we have interpretation that's available in French. So if you click the globe button on the taskbar below, you can get access to the language that you prefer to listen to. That's available in French and the original language in English. Next, please. We also have the live transcription. So if you can go to the live transcript tab below, and you can either choose the options of show subtitle or hide subtitle to kind of get access to the live transcription as you prefer. Next, please. We are going to have Q&As after each country presentation. But also there is the chat function. So you can please feel free to pose your question in chat. And as we go through the questions, we're going to kind of come up with the discussions to try and respond to your questions on the chat. Next, please. So for this, the session will be recorded, and all the consent that is by attendance is the consent that we have for being recorded for this session. Also, I wanted to kind of reiterate, and I'm going to talk about that towards the end, that you can obtain a certificate of attendance through the University of Mexico by after the end of the session by clicking the link that's available, which we are also going to put in the chat, just to do a post-session survey. There's a few questions. There's a 5-minute survey, and once you complete the survey, you can get the certificate of attendance for this session. Next, please. For the data use, Project ECHO collects the registration, the participation, the Q&As, chat comments, and poll responses for some ECHO programs. Your personally identified data will be shared with the project funder, and the data may be used for report, maps, communication, survey, quality assurance, evaluation, research, and to inform new initiatives. Next, please. Yeah, before we get started, we just have one icebreaker activity, and we'd like to go kindly request all the participants to take this poll question. Can we have the poll question up on the screen, please? Yeah, so this is the introduction poll, and I'm going to read out the question. In your opinion, what are the 3 biggest COVID-19 vaccine barriers for the population of concern, which is the refugees, the internal displaced people, IDPs, and the migrants that are facing? So you have an option below, but you please select only 3 of the responses below. The first being administrative barriers, including identification, documentations, etc. Restrictive national policies, no access to healthcare, financial aspects, technical obstacles, no internet or online access, lack of adequate information and mistrust, vaccine availability, logistic hurdles, and discrimination. We'll give it a few more seconds. Please kindly requesting you to take part in the poll. Good, we have about 50 and we're, okay, good. Oh, we can stop here, and then can you show the responses, please? So based on the responses below, you can see that the majority of them, they feel that The biggest challenge first being the lack of adequate information and mistrust, which is about 68% of the participants feel that's the primary thing. The second being administrative barriers that include identification and documentation. And the third one being restrictive national policies or no access to healthcare. Thank you all for participating in this poll, and over to you, Diana.
Great. So can I close this window?
Yeah, you can close.
Okay. Great. Super. Next slide, please. Great. So could I kindly invite Anne, and maybe Anne, you'd like to say a few words about yourself as well before you kick off your presentation. Thank you.
Yes, good afternoon, and thank you very much, Diana and Santosh. My name is Anne Burton, and I'm the Chief of the Public Health Section for the UN Refugee Agency. I'm very, very happy to be here today talking about, well, setting the scene on a COVID-19 vaccination in humanitarian settings. Next slide, please. So during this presentation, we're going to just run through, so firstly, who are populations in humanitarian settings and why is it important to reach these populations? Just give a very brief overview about UNHCR's public health programming, and then what have we done to roll out COVID-19 vaccination in refugees, what has been achieved, and why it's important to monitor the vaccine rollout, and then end with lessons learned and opportunities. Next slide, please. So in 2022, there were 274 million people globally in need of humanitarian assistance and protection. And these include internally displaced, so populations that are displaced within the borders of their own country, includes refugees and asylum seekers who have crossed an internationally recognized border, and then also non-displaced conflict-affected populations, and then migrants who are affected or caught up in humanitarian emergencies, and then populations affected by natural disasters, including climate-related events. Now, this 274 million is an increase from the previous year, where it was 235 million. And it also does not include the population that has been affected by the Ukraine crisis, which has led to the largest displacement crisis in Europe since World War II. Next slide, please. So why is it important to talk about reaching humanitarian populations? Well, firstly, these are some of the most vulnerable populations globally. They are often, the majority are hosted in low or low middle income countries, which lack sufficient domestic resources to put towards reaching these populations. They may not be included in national health systems, and even if they are, the national systems are often fragile and unable to adequately extend services towards these populations. This is compounded by the fact that they're often hosted in remote and underserved parts of countries, or they may be difficult to reach for other reasons due to insecurity. Many of these populations have been living through crisis for a number of years and living under substandard living conditions and have pre-existing poor health status, which makes them vulnerable to disease and vulnerable to adverse outcomes. In other contexts, they may be deliberately excluded from national programs, particularly when living under areas that are under the control of non-state actors. So the COVID-19 pandemic has shown that how important it is when we're talking about not only about people's rights to access health and to reach the highest attainable standard of health. But when we're talking about communicable disease control, how important it is that countries have inclusive policies that are inclusive of all populations in order not to leave anybody behind. And so if we don't include these populations, we will not reach national targets and we won't reach global targets. Next slide, please. So just very briefly for UNHCR, and this is what the slide is actually going to focus on in particular, is refugees, but our primary purpose is to safeguard the rights and well-being of people who have been forced to flee. This includes refugees, asylum seekers, but also internally displaced. As I said, the numbers in front of you don't include the massive displacement crisis that has resulted from the conflict in Ukraine, which you would have seen for the first time this year. We have reached over more than 100 million people displaced globally. UNHCR also has a mandate for stateless populations, though they're not necessarily humanitarian. Next slide, please. So for our public health programs, we are supporting public health in over 50 countries globally. Depending on the country context, we're working throughout all phases of the displacement cycle, from preparedness to response and to eventual return home. We work through partners, mostly governments, but also national and international non-government organizations, as well as the Red Cross and Red Crescent. Next slide, please. So in terms of our approach to COVID-19 vaccine rollout, so firstly, there was a big emphasis on inclusion in national vaccine deployment plans, or the equivalent. So with the onset of the pandemic, we were able to leverage long-standing relationships with hosting governments and progress towards inclusion to very successfully include refugees in most national COVID-19 vaccine COVID-19 preparedness and response plans, and also in the vaccine plans. Also at country level, we participated in micro-planning at subnational level and also planning at national level, ensuring that persons of concern were included, that the particular challenges to reach these populations were taken into consideration. Also bringing vaccine delivery sites as close as possible, and providing numbers in the vaccine target group. We adapted the vaccine introduction readiness assessment tool to refugee contexts, and this was used to assess vaccine introduction readiness and consideration for inclusion of persons of concern and gaps in preparedness and actions more at the subnational level. We also, there was a big emphasis on risk communication and community engagement, adapting national communication tools, and then using all contacts with persons of concern to reach them. This included, for example, in Lebanon, engagement of refugees to design, deliver, and promote vaccination campaigns. Monitoring of rumors and misinformation was an important part of that. Next slide, please. We also supported health partners, so funded partners to support the government in the national vaccine rollout in the more remote areas of countries. And then last mile logistics and system support where needed. So we were careful not to duplicate. So in some countries, we did support cold chain if the Ministry of Health or UNICEF support was not able to reach the refugee hosting parts of the country. An important component has been monitoring and compilation of data, looking at the progress and gaps at country level. So we were looking at the extent to which vaccines were reaching refugees, looking at the coverage, looking at the reasons refugees weren't being vaccinated, and also monitoring adverse events. And then lastly, we're using all of this information to address barriers. At the beginning, though, most of the countries included refugees and other populations of concern in the vaccine rollout. There were quite a number of reasons why they weren't being reached at the same pace as what nationals were. And that included, for example, not having access to the internet when it was an online registration system, or not having national ID documents. So in some countries such as Jordan, we were able to negotiate for the use of the UNHCR registration certificate to register for the vaccine. We also supported 2 humanitarian buffer applications in Iran and in Uganda. Iran, for example, received 1.6 million doses through the humanitarian buffer to vaccinate over 800,000 Afghans. Next slide, please. And just to note as well that we were also, where necessary, we extended that support to the surrounding host community. So what did we achieve? So in 2021, the 162 countries that we have been monitoring included refugees in their national COVID-19 vaccine plans. In 153 countries, we were aware that refugees or other persons of concern had been vaccinated. In the 70 countries from where we had data, 10.6 million vaccine doses had been given to approximately 6.1 million persons of concern, most of whom were refugees. Now, we're well aware that these are absolute numbers and they don't tell us about coverage, and we'll come to that. But we also know that that we're not capturing or not able to capture, for various reasons, all of the doses that have been given. So this is how many we know have actually been given, but we know that the real figure is likely to be much higher. Next slide, please. We also have
Anne, I apologize for interrupting, but I'm just going to have to ask you to speed up a bit so we can get through the other 2 presentations. Thank you.
Sure. We also have this data broken down by the numbers of doses that have been given by region. As I said, this is also a quality of the reporting. Next slide, please. So we are able to compare with the data that we have, the number of refugees vaccinated compared to the number of nationals. And we know that in most of the countries for which we have data that we're reasonably confident, the rate of refugee vaccination is lower than that of nationals. There's a few caveats with this data in that we're looking at the national average, and and if we were comparing, for example, with the host community, the immediate surrounding community, we may not get the same result. We also may not be aware of all of the doses that refugees have received. Nevertheless, it's useful to make these comparisons and to highlight where we need to look more deeply. Next slide, please. And these are some of the methods that we use to monitor vaccine coverage. We try to encourage the use of robust methods, including COVID-19 vaccine coverage modules in existing surveys, but we also did sort of more convenient sampling where we weren't able to do surveys. Next slide, please. So some of the results, and just I'm not going to go through all of these, but for example, in Pakistan this year, we conducted a health access and utilization survey and found that 65% of Afghan refugees had received at least one dose, and 55% reported being fully vaccinated. In Iran, the result was extremely promising, with 92% of Afghans having had at least one dose, and 92% of those again having had 2 doses. But then you come down to countries like Egypt, where, and this was in November of last year, so we couldn't get updated data in time for this. Only 10% of refugees had been vaccinated compared to 20% of nationals. And we also saw differences in where the refugees, Arab-speaking refugees, had a much higher rate of vaccination than refugees from the sub-Saharan Africa. Next slide, please.
And 1 more minute. Sorry to rush you.
So
Thanks.
just lessons learned, the majority, so though the majority of governments adopted inclusive policies and approaches, most of them needed support to reach refugees. The second is that vaccine hesitancy, while present, we shouldn't assume that the reason for suboptimal vaccine coverage is due to hesitancy, and we need to look at why these populations aren't being vaccinated. Similarly, geographical and other differences should be considered. So rather than looking at aggregate data, we need to look at, we need to look at different gender and age disparities. Next slide. And then the humanitarian buffer, while it greatly assisted to overcome supply shortages, now that supply is much less of a problem, the utility of the humanitarian buffer is probably much less, and the delivery partnership provides opportunities to overcome country-specific barriers. Engaging at all levels was critical, and then lastly, as we've shown with the data, that it is really important to monitor vaccine coverage in these populations through either population-based surveys, but also convenient sampling, and then disaggregated data from national health systems. Next slide. Thank you very much, and back to you, Diana.
Great. Thank you so much, Anne. First of all, to UNHCR for the extraordinary work you've done to reach these most vulnerable. And secondly, to apologize to you for having to ask you to truncate your presentation because it's actually very rich and very interesting and probably deserves more time. So thank you so much. What I'm going to ask participants is we don't really have time for Q&As, unfortunately, on Anne's presentation, but certainly type any reflections or questions you may have in the chat. And I'm sure Anne will be happy to respond to them in the chat. So if I could move us now to our next speaker, Ms. Hajar Samaha from the Ministry of Public Health in Lebanon.
Yes, hello everybody. I am Hajar Samaha, Public Health Officer at Preventive Medicine Department and Ministry of Public Health in Lebanon. I will give you a presentation about COVID-19 vaccination strategies for refugees and migrants in Lebanon. Next slide, please. Lebanon is a country of 10,452 kilometers square that hosts 5.6 million inhabitants, of which around 1/3 are refugees. Almost of them are Palestinians and Syrians and migrants. 400,000 of refugees are Palestinians since 1948, which is the largest refugee population per capita in the world, and 210,000 migrants. The Lebanon's healthcare system is characterized by a dominant private for-profit sector that offers up to 75% of all health services, and the public-private non-for-profit network covers the rest of the population, namely the economically deprived and the most vulnerable inhabitants. Next slide, please. The country is witnessing an unprecedented severe complex emergency. We have the financial and the socio-political crisis. We have a political instability, the explosion of Beirut port compounded by the current COVID-19 outbreak, and the electricity and the fuel crisis. All these factors resulting in fragility of the healthcare system. Next slide, please. Lebanese government is committed to the Sustainable Development Goals and leaving no one behind. Ministry of Public Health has also committed into ensuring UHC with focus on most vulnerable persons. The Preventive Medicine Department and Ministry of Public Health is responsible for the deployment of COVID-19 vaccination, but it is not a part of AP program. The vaccine deployment started in February 2021 with Pfizer vaccine through bilateral agreement funded by World Bank loan. Lebanon also joined COVAX facility as a self-financing country, but did not receive through humanitarian buffer. Lebanon received many vaccine donations from various countries. Near expiry was an issue. And the Ministry of Public Health also encouraged the private sector to ensure enough vaccines for the corporate sector. Next slide, please. Since the start of COVID-19 vaccination process, Lebanon used the following vaccines. We have different types of vaccine. Pfizer vaccine, 80% of total administered doses. AstraZeneca vaccine, 12.5%. Sputnik 5, 2%. Moderna, 1%. And Sinopharm, 0.4%. Vaccines were administered for free for all people residing in Lebanon, following the priority guidance set by WHO at the beginning of the vaccination. All people were asked to have a pre-registration on online platform. We have the Impact platform and should register on it. The current vaccination coverage with 2 doses is 44% of the target populations, those who are 12 years and above, and 79% for elderly, 65 years and above, and 70% for healthcare workers. Next slide, please. What is the current vaccination policy in Lebanon? The only current vaccine used is Pfizer vaccine based on walk-in basis. No need for appointments anymore. Any person can get the vaccine by walk-in. all persons who are 12 years and above are eligible for the first, second, third, and fourth dose. The second dose be taken 3 weeks after receiving the first dose. The third dose should be taken 5 months after receiving the second dose, and the fourth dose should be taken 6 months after receiving the third dose. The pediatric doses are available and offered for those who are between 5 and 11 years old, but we have a very low intake. Only the first and second dose can take it. All individuals are available for free vaccination, irrespective of nationality. Vaccination is regularly provided at hospitals. Most are private hospitals and some PHCs, primary healthcare centers, total of 72. Vaccination marathons are conducted. Vax are deployed in low uptake areas for community vaccination and mobile units for elderly homes. Who are the key partners of Ministry of Public Health? We have the UNRWA, UNHCR, IOM, WHO, UNICEF, World Bank, and many international and local NGOs. Vaccination sites, public and private hospital, primary healthcare centers, and municipalities. Next slide, please. The COVID-19 vaccination among refugees and migrants, we have different nationality for the Lebanese, Syrians, Palestinians, and others who are registered are approximately 3 million Lebanese, 595,000 for Syrian, Palestinian 122,000, and other nationalities 273,000. So the percentage of administered doses, 82% for Lebanese, 10.9% for Syrian, 2.75% for Palestinian, and 4.4% for others. These data are extracted from Impact platform on October 6. Next slide, please. What are the specific challenges related to COVID-19 vaccination among refugees and migrants? We have 52% of Syrian refugees in Lebanon is under the age of 18 years old. This is one of the reasons for low coverage. Based on the priority group, at the beginning of the vaccination and due to age, Syrian refugees had specific vaccine hesitancy toward AstraZeneca due to safety of vaccine. Pfizer was made available for healthcare workers and elderly only. Some Palestinian refugees were not able to leave camps due to security reasons. Transportation cost to vaccination site was a barrier for all people residing in Lebanon. Registration online that requires internet and smartphones was a barrier to some concerns about personal information shared online, and with vaccination sites, fear of deportation. Need to have a valid ID to receive the vaccine was a major barrier, and migrant workers cannot take days off or go to get the vaccine during working hours. Next slide, please. What is the role of Ministry of Public Health and key partners concerning the COVID-19 vaccine strategies? Concerning the Ministry of Public Health, the concrete strategy is provided vaccines for free or regardless of nationality, first based on priority groups, based on SAGE recommendations, then to everyone. Issue detailed document on identification documents to be allowed, expired documents, identifications paper from embassies, municipalities, UNHCR, UNRWA cards, among others, were all accepted. Ensure the confidentiality of information collected by online platform, organized marathons during weekends, and allowed walk-ins, no need for registration. They can take the vaccine immediately. Running VaxPass with support of international NGOs in rural areas and coordination with municipalities. Concerning the UNRWA, secured extra vaccines earmarked for Palestinian refugees, conducted massive registration campaign with Lebanese Palestinian Dialogue Committee, opened a vaccination clinic in Ain al-Helwi camp, It's a camp for the Palestinian refugees. Ask teachers in UNRWA schools either to get vaccinated or provide a negative PCR once per week. Concerning the UNHCR, community engagement activities with local NGOs supported in online registration, establishment of vaccination sites at PSC in rural areas where we don't have enough hospitals, run mobile units, supported some vaccination hospitals with fuel to avoid risk of cold chain disruptions, vaccination in schools during second shift dedicated for refugees to vaccinate teachers, parents, and students. Next slide, please. The IOM helped us to coordinate with embassies, mainly Ethiopian and Bangladesh embassies, coordinate with Ministry of, or in coordination with Ministry of Labor, provided operational support in terms of awareness, support online registration, provided transportation, paying hospitals to dedicate weekends to migrant workers, setting up pop-up vaccination events in specific hospitals, advocacy support, outreach activities, and providing incentives supporting Beirut municipality mobile clinic for vaccination with dedicated day per week for migrant workers in a fixed point. Concerning the WHO, they provide us a financial support to vaccination sites at hospital for each dose administered, regardless of nationality, and provide support to the National Pharmacovigilance Center to facilitate the reporting of adverse events. Concerning UNICEF, we have the co-leading with Ministry of Public Health and other partners, the RCCE task force, production of awareness material, leaflets, question and answers, videos, posters, and social media posts, initiation of community and social listening, info tracker to detect and address rumors and hesitancy, outreach activities and OT training of trainers among youth and other specific groups, social mobilization of volunteers for marathons, coordination with religious leaders and faith-based organizations to re-emphasize that vaccination during Ramadan is not prohibited. World Bank support us to develop an offline platform for registration and facilitate door-to-door activities, a third-party auditor on vaccination side. Concerning other NGO support in marathons, mobile units, VaxPass, and mega centers. Next slide, please. What are the current challenges concerning the COVID-19 vaccination in Lebanon? We have a miss or this and malinformation about this issue, competing priorities, elections, daily economic concerns, relaxation of COVID-19 control measures worldwide in Lebanon, decline of daily COVID-19 deaths and cases, safety concerns of the vaccine and symptoms across some groups, especially youth, introduction of a new COVID-19 vaccine brands, paving the way to new discussions, queries, and fake news, and the breakthrough infection. The fatigue of vaccination sites, the high rate of the transportation costs, consider expanding vaccination sites to selected primary healthcare centers at rural areas, need more mobile units to vaccinate people, booster doses in confined places like prisons, elderly homes, and long-term facilities. Next slide, please. What worked well? Have a national vaccination deployment plan with clear priority groups, a detailed SOPs for vaccination teams for each vaccination type administered, an independent consultative committee and an executive committee, the vaccination process being done at hospital setting more at public hospitals, centralize the storage of vaccine with transportation secured from vaccination centers, having audits done by a third party from the storage to administration to identify gaps to be addressed, having a centralized online registration with standardized vaccination certificate, access to the public for accurate number of doses administered per age, location, occupation type, among other things, a clear communication strategy under the NDPV, continuous media post, and the coordination with all relevant partners. Next slide, please. Finally, the COVID-19 vaccine should restore our lives, not divide us. Thank you. Over, thank you.
Great. Ms. Samaha, that was superb, really superb presentation. So interesting and really got across the complexities of the Lebanese program and the interrelationship between all the roles and responsibilities of all the actors and the success you've had to date despite the challenges. So thank you so much. So we have a few minutes for questions and answers, not a lot, maybe 5 to 7 minutes because we're running a little bit late. What I would ask is if you'd like to ask a question, feel free to type it in the chat if you prefer, or go ahead and raise your hand. I think we can take people's raised hands. And while people are reflecting on that, I have a question in the chat, which I'll throw out after we ask Dr. Salim to ask his question. So we had a question in the chat about why countries have not applied to the humanitarian buffer. And my colleague Alice will respond to that. But in the meantime, we'll ask Dr. Salim, please go ahead.
Well, thank you very much for inviting me. I'm Salim Mohammed Noor from Khartoum, WHO, Sudan. I just want to ask if there is any studies specifically for seroprevalence antibodies for COVID-19 among refugees, either in Lebanon or globally. Thank you. And over to you.
Anne, I think you might have a reply to that.
Wants to come in.
And who wants to come in?
Samaha.
Okay.
Lebanon.
Okay, so why don't with Dr. Samaha first, and then if you had something you wanted to say, and then Anne Burton.
In Lebanon, in coordination with the AUB Medical Center, we have a seroprevalence study, but only for Lebanese. We ask UNHCR if they have any study about UNHCR, Syrian refugees or other persons. Thank you.
Yes, thank you very much. For refugees, there was a couple of countries where a seroprevalence study was done, but we haven't actually seen the final results. So I wouldn't really like to say anything. Just to say that the reason for doing the seroprevalence study was not to monitor the effect of the vaccine, but to see whether or not the people had been exposed to COVID and not necessarily being picked up through clinical means. Thank you.
So thanks also from my side. My name is Alice Wimmer and I work for the COVID Delivery Partnership. And thank you so very much, Hajar and Anne, for your excellent presentations and showing really where the problems lie to reach populations of concern and how they can be overcome. With regards to the buffer, and I think actually it would be much more helpful to ask us the countries and additional humanitarian actors why the appetite was not so large. But I think it was not an easy process from the onset. It was very much about competing for doses. And I think it was while the epidemic changed, the funding needs became more evident to reach the last mile rather than the additional doses needed, because they were more often than not already available in the countries. So it's more, I think, the innovative strategies that Lebanon could apply to reach the various populations on their small territory is a very wonderful example how humanitarian populations can be reached. I think until today, and I don't want to open this very discussion, there are still issues with NGOs and contractual arrangements with regards to the buffer. So the two countries that Anne, that UNHCR and other organizations assisted to write these very proposals were led by the ministers of health of the two respective countries that ultimately had the successful vaccination campaigns. Over.
Great. Thank you very much, Alice, for the clarification. I have a comment in the chat from Ibrahima. I'm not sure if that's just a reflection or a query to the group. Did you want to come in? If I understand the question, it's about those who are vaccinated but are having breakthrough infections and whether or not they would have the opportunity to get re-immunized, if I understand the question. Okay. Okay, Ibrahim, if you have a further clarification or reflection on that, you can continue to chat, put that in the chat. Can I have Kasu Dade, please? I think you're still on mute, Kasu.
Okay, so my name is Kasu. I'm from Ethiopia, and I'm working in, as a COVAX technical assistant. And I do have a question on presentation, especially doses administered for other migrants is only around 4%. So I wanted to be cleared on this issue, particularly why is the reason behind this? Because this segment of population needs huge concerns, and the issue of equity should have to got special priority. So I want to be briefed, or I wanted to be cleared on these issues. Why those immigrants are only vaccinated? 4% of them are only vaccinated. Thank you. Over to you.
Great, thank you, Kasu. Hajar, did you want to answer that in terms of why migrant coverage might be significantly lower?
In Lebanon, overall, we have a low rate of vaccination. So 50% as a global, from those who are registered, took the vaccine. Mainly, they took the first and the second dose. Concerning refugees, we, in coordination with other NGOs, WHO, UNHCR, we conduct mobile clinic and vax buses to raise the vaccination uptake among these categories. Thank you.
Great, thank you so much, Dr. Samah. So we have one more question in the chat, and with apologies to my dear colleague Imran, because we're short on time. It's a very good question about how Lebanon reached unregistered. Dr. Samaha, if you could actually type your answer in the chat so we can move to the next country presentation. I'd want to make sure we have enough time for that. So if you could kindly answer Imran's question in the chat, that would be fantastic. And I am now going to open up the pathway for our Sudan presentation. So could I ask Dr. Islam Ahmed, so excited you were able to join us, even if late, and handing it over to you. Thank you.
Thank you very much, and I apologize for joining in late. It's just that we are in the section retreat in a remote farm, so sometimes we're expecting some connectivity issues, but for now things are fine. I'm going to quickly walk you through the Sudan experience and the readiness for the mega campaign. The mega campaign.
Dr. Islam, can you put yourself closer to the microphone, perhaps? Oh, shoot.
October 20th, sure. Can you hear me better?
Yes, we heard you very well in the beginning, and then the past 30 seconds, not at all. We seem to have lost you again.
Can you now better? Can you hear me better
Sometime-
now?
Oh, yes. You seem to go in and out.
Okay, is it better now?
That's perfect. What you're doing, stand still. Stay exactly there. That's perfect.
Okay, thank you. So we are expecting the first mega campaign in Sudan on the 22nd of October. And these are some of the readiness for the mega campaign. Next. Next slide. Oh, yes. So the mega campaign slogan this time around, it was based on the evidence from the perception survey and from the rumor tracking application. Because at the current time, we cannot enforce policies due to the fragile political situation, which might backfire. So we are relying on the Sudanese culture for collective action and the drive to help each other and to work together. So the campaign slogan is called Bridge the Gap. It's from a Sudanese news, the tongue twister, to come together. So we call it Nasid al-Faraga. For those of you who are from Arabic speakers, maybe you can relate to this. So the idea behind the campaign is to have people come together and achieve the vaccination target, to give the community the sense of ownership. And also the vaccination campaign this time around is going to rely on incentives for those who are vaccinated, while through bundling vaccination with other services, with events or products or activities. This time also the coordination between the demand and the supply has started very early in the process. And also we have engaged partners with us. As we go through the presentation, we're going to look at some of the key partners that are going to be supporting in this mega campaign. There's also going to be edutainment activities, that is educational entertainment activities, like roadshows and activation sites in low coverage states. These are 5 determined states based on the vulnerability analysis and on the vaccination coverage, and also on geographical locations, take into consideration a state, the northern states, also the eastern, the western, the southern, and the central states. Also, the campaign is focused more on gender-sensitive incentives, like mobile cinema, marrying the mobile cinema with the mobile bakery of some of the big food producers that have mobile bakeries. These mobile bakeries, they target females in remote areas. So we are marrying the mobile cinema with the mobile bakery to encourage women to get vaccinated, and also have vaccination teams with the mobile cinema and the mobile bakery as a package. Also, we are advocating for the need for privacy within the vaccination center, and also for female vaccinators, as the perception survey results have shown that in Eastern Sudan, females tend to have a more need for privacy and a preference for female vaccinators. Partnership is it's a big investment also for this campaign, and also the use of national ambassadors, champions, and influencers as promoters for this campaign. We have already started shooting with some of these influencers so that we can brand the campaign with influencers and champions in an attempt to increase the vaccination coverage. Youth partnerships are also very strong this time. We are counting on youth to increase the reach, access, and creativity, and also on their digital capacity. Before the campaign, we have conducted the perception survey, and following the campaign, we are planning to conduct a post-campaign assessment also to see the results of the SPC interventions. Next, please. Here are some of the preparations also. Advocacy, communication, social mobilization plan of the national deployment vaccination plan have been updated and revised. Field supervisors meeting and after action review to provide some evidence and guidelines on the way forward. The micro planning guidelines have been developed and the states are now finalizing their micro plans. We have conducted also social media workshop for federal social media influencers. These are for national influencers, and also state social media training for social media admins for the federal and the state Ministry of Health, so they're better capacitated to disseminate the message and create an attractive content for their social media websites. Next. The rumor tracking application is under development to assist the Ministry of Health to collect, to timely collect rumors from the states, and also with the visualization of the rumors. M&E workshops have also been conducted in 3 phases. One workshop for the federal state, and 2 workshops for the state levels. We have trained 54 people from the state. That is 3 individuals who are working on M&E from each state. The perception survey led by Acacia, that is a company hired to perform the perception survey under the lead of the Ministry of Health and with the technical and financial support of UNICEF. And the findings of the perception survey were shared in the last NTC meeting, and these findings were used to inform the communication strategy for the campaign. Next, please. These are some of the photos of the social media influencers training that took place on the 15th of October. Next, please. The previous slide was talking about the social media training for the national influencers. This one is for the state social media platform admins training, just in preparation of the campaign. They were oriented and briefed on the social media strategy and the slogan and the hashtags that are going to be used in the campaign, just to create synergy between all partners that are involved within the campaign. Next, please. Here are some of the findings of the perception surveys. And these findings are quite bright for the vaccination. And this is a table reflecting the willingness of people in the 5 states to get vaccinated. And if we look at the willingness, we have for the yes, people who are willing to get vaccinated, the total is slightly above 50%. So in terms of willingness, we have more than 50% people who are willing to take the vaccine. We have about 20% that mentioned that they don't know. So these people just need a little push. They're slightly hesitant, but that's through social mobilization and community engagement and effective communication, they can be reached. We have a striking also just below 30% that mentioned that they will definitely not get vaccinated. So these are hardcore refusals, and they need to they need a policy in place enforcing vaccination to get these hardcore refusers to get vaccinated. Next, please. This is the what has been done so far on the communication strategy. To the right of the slide is the slogan and the logo of the campaign. It's called Nasid al-Faraga, which is let's bridge the gap that we have in vaccination, and it also says under it the COVID-19 vaccination campaign. And so far, 4 posters have been designed targeting elderly, women, youth, and also speaking about adverse events following vaccination. And also there is a vaccination table that includes the new mix and match guidelines. These are the main focus in terms of printable. Also, billboard designs are in place for elderly, women, and youth. And we also have celebrities from the elderly, namely a famous singer, Abdelkader Salim, who has done the photo shoot, and he's now also on the designs. For the women, we have Insaf Fethi, she's also a popular female singer. And for the youth, we have a football player that is one of the famous national football player. His name is Atish. We have also a campaign announcement, audio and animation are ready and have been endorsed by the NTC, and they're due to be broadcasted today or tomorrow. We have the script for a youth song and an operate song reviewed and endorsed. And the youth song is also has been recorded, and we're expecting the video clip to be shot tomorrow, inshallah. We've also started on the influencer video. We shot because of the gender sensitivities and the gender-related rumors to vaccination, we made it a priority to target a senior officer and gynecologist to address some of the concerns around the gender and vaccination. And we also targeted the footballer, and the main message for the footballer was to the youth, that the youth, even though you're strong, you can still contract COVID and you can be a source of infection to your loved ones. So this is the main message that we are selling to the youth to be part of the campaign, and so as to increase their risk perception that they are at risk, and also they can be a potential source of infection to their beloved ones. Also, we are targeting Dr. Ahmed Shadul has also shot his part of the influencer video. He's the Secretary General of the Sudanese Medical Specialization Board, and his main message was targeting vaccine adverse events following immunization and the need for immunization of elderly and immunocompromised. We also have 2 religious leaders on board to speak about the importance of vaccination and protecting oneself from the religious perspective. Also, next please. These are some of the background photos. We go to the private sector engagement. Next. We have several private sector on board, from transportation companies offering to give discount, 30% discount for people who are going to the vaccination center, also offering to send mass messages and app notification. We also have the telecom companies on board offering to assist with bulk SMS and reminders, and also giveaways. Next please. Also, food companies like Coca-Cola are also interested in being part of the social media campaign, and other famous transportation company Sehal is also interested in offering social media platforms and hashtags, sending bulk SMS, and also sending flash messages and also coordinating a class vaccination day. Next. The youth, as we've mentioned, are big on the agenda, and we have several workshops with
Sorry, Islam, we have lost you again. Are you still speaking into the mic?
Yes.
Oh, yeah, that's better. Thank you. That's better. Thanks.
Okay. The Meds in Sudan, these are the Medical Students International Network, Sudan. These are the key youth that are being targeted in this campaign for two reasons, is that they have a strong presence in almost all states of Sudan, and they have over 90,000 membership. And the second reason that this group is being targeted is that Sudanese culture places high emphasis and high trust on doctors. So being a medical student, they have a higher convincing power and influence over their peers and over the communities. The areas that this group can collaborate and contribute to the campaign is evidence generation, as to identifying the barriers of vaccination among the memberships. They've also offered to assist in campaigning in campus and outside campus, volunteerism for community engagement events. They're also going to participate in social media and assist mainly through TikTok. This is an area that we have fallen short of. We're usually working with Facebook and WhatsApp, but Twitter is a new platform that we are going to explore with the youth. Rumors tracking on social media platform. They also suggested a tournament, a competition as for which university is the best university in terms of COVID-19 vaccination coverage. They can also advocate for vaccination policy enforcement within the campus. Next, please. Here are some of the examples of the private sector engagement that have been conducted over the last campaigns. One very famous is the one with Dal Food Group. Dal Food Group is the biggest food group in Sudan. They have offered us 20 trucks and 15 billboards. These 15 billboards are in prime locations across the greater Khartoum North, and Omdurman. Next, please. We also have some challenges that we anticipate for the coming campaign is the competing priorities, namely political instability, security, access, monkeypox, and other floods and emergencies. And we also have 2 critical days around and within the campaign. That's the 21st of October and the 25th of October. The 21st of October marks a historical day for the Sudanese revolution back in 1964, I think. I'm not sure, but it's somewhere in the 1960s. The 25th of October marks the memory of the political movement that happened of the military movement that happened last year in Sudan. So we're expecting a bit of an unrest during this period. The COVID-19 communication fatigue is also, it's a global issue and it's also a local issue. We are expecting a challenge in timely and regular data collection and visualization. Also, we are expecting that COVID-19 campaign is going to adversely affect the routine immunization in terms of human resources, because the same human resources that are working for routine immunization will be very busy with the COVID-19 vaccination. Inadequate COVID-19 vaccination policy enforcement to support social behavior change communication efforts, especially for the health workers. The health workers, they play a very critical role. As mentioned earlier, they're very trusted in the community, and the words, and if we have health workers that are opposing vaccination, their families and the people around them are also likely going to oppose vaccination. We also have high turnover for human resource, especially in the States, weak M&E system, but there's a substantial effort that has been done to resolve this through the capacity building conducted for the federal and the state health promotion personnel, and also through the M&E tools rollout. That's basically it. And the competing priorities are also one of the major hurdles that are expected. Next. Thank you very much. With this, I come to the end of the presentation.
Thank you so much, Dr. Islam, particularly because you're in such a remote area, for making the effort to give that presentation, which was very informative, very interesting, and you're at the cusp, as we understand it, of a very big initiative on the 22nd of October. And we certainly hope Sudan is successful in bridging the gap the way you've described the number of activities. I thought it was actually really fascinating how much the energy of the youth is being used, and the social media campaigns and the social media influencers. So super interesting. I know it's a very big endeavor you're about to launch on in the next couple of weeks. So we don't have, unfortunately, a lot of time for questions and answers as usual, but if I could just ask you, Dr. Islam, to elaborate a little bit on, of all the things that you described, the very kind of multi-pronged strategies, what aspects of it might be targeted or specific to IDPs or refugees or migrants? Is there anything among the slides you described you wanted to enhance a bit more around some of those targeted strategies?
Thank you very much, Santosh. I think yes. To us,
and could you stand closer to the mic? Sorry.
Yes, sorry. To us, can you hear me now better?
Yes, very well.
Yes. To us, the migrants and the IDPs and the refugees are treated like the host communities. They're included in the national vaccination deployment plans, and the states that cater for the host communities and for the refugees and the IDPs. They do tailor messaging in local languages for these specific populations. I hope that answers your question. Thank you. Over to you.
Yes, that's perfect. We had a question in the chat. We probably have a little time for that. I think if you could also characterize a bit the 27%, you said that are kind of firm decision makers about not getting vaccinated, if you have any greater sense of the characteristics of that subgroup.
Most of them, they have been males. The females had a higher risk perception and were more willing to get the vaccination. But the females had an issue of lack of time to actually reach the vaccination center. Most of them were busy taking care of the chores, the house chores, and the children. So it's quite variable, but it's mainly the men that are hardcore refusers. Thank you.
Great, thank you. Very clear answer. I'm afraid we're out of time because we have to just run through some closing issues, but there is a question about monkeypox in the chat and whether that's affected at all uptake of COVID-19 in Sudan. So if you are familiar with anything around that, Dr. Ahmed, if you could reply in the chat, that would be terrific. And on that note, I'm going to just give a very sincere thanks to the three speakers for the three excellent presentations. Really, honestly, very informative. I learned a lot myself. So thank you very much for taking time out of your very busy schedules to share with this group. And on that note, I'm going to pass it on to Santosh Gurung for the closing.
Thank you, Diana. Thank you once again, speakers, for this excellent presentation. We have a few wrap-up slides. Before we get into that, just maybe one closing poll questions. And can we have the question up on the screen? So this time, can we have the question, please? Yeah. So for the question this time, we have, what would you do differently in a future pandemic to ensure that there's equitable vaccine access in this population of concern? There are multiple choices. Could you select three, please? The first being focus to reach 100% of the priority use groups, such as the healthcare workers, the elderly, the comorbidity group. Outreach and mobile vaccination team focused on this population. Easy registration platform, not requiring ID. Ensure all this population are included in the microplans. Large-scale RCCE campaigns via different channels. Integrate COVID-19 vaccination into the routine immunization services. Improve data collection and reporting of the disaggregate data by refugees, IDPs, and the migrants. And lastly, would you not do anything differently? Thank you, and we'd appreciate if you can take part in the responses. We'll give it a few more seconds. We have 42% of the participants that are responding to the question. Give it a few more additional 10 more seconds, and then we close this poll to reveal the response. All right, can you end the poll, please? And can you show the responses on the screen? Thank you. And the responses, majority of saying outreach and mobile vaccination team focused on the preparation. This was the majority of the participants feel that is the response, which is 69%, and 53% of the field felt that ensure all populations are included in the micro plans, and 47% feel that large-scale RCC campaigns via the different channels. Thank you very much. Can we close the poll and then move on to the next slide? Just a few wrap-up slides. Yeah, thank you. So for the next session, we have on November 15th, we'll be talking about the best practices on the COVID-19 strategy, and really the topic around integration into primary healthcare and essential services, and immunization, routine immunization. So please kind of register using the link on the right. And we look forward to more participation in the November 15th. We'll have two countries present their case presentation around integration around primary healthcare services, routine immunization, and other interventions. Next slide, please. So for this, this is something that I wanted to kind of re-emphasize, that you will receive a certificate of attendance through the University of Mexico. And in order to obtain the certificate, we'd also kind of request you to do a post-session survey. This is a 5-minute survey, a few questions on the survey, and we'd really appreciate your feedback so that we can improve the future sessions and the series in the future. So kindly to the link, and thanks for also adding the link in the chat. To the next slide, please. all of these resources will be available in the TechNet. You can see the link, and then for all the participants that have attended the session today, we will send a follow-up email with all the resources where it's available, all the recordings, all the slide decks, and so on. And also there is a Telegram group within the COVID-19 vaccination rollout, and that's the link to join the link. And you can also have access to some information around the next session, around COVID-19 vaccination technical resources. So it's all available through the Telegram chat. To link in using the to join using the link or the QR code that you can see on the screen. Next, please. Yes, once again, thank you very much. Thank you for the speakers for a really excellent presentation, to all the participants who have taken time to join and listen to the session. Have a good rest of the day. Thank you very much for joining.
Thank you. Bye.
Bye.